Yes, sir, we can start.
Good morning, all. Respected teachers, fellow colleagues, and my dear students. On behalf of Sri Siddartha Academy of Higher Education, Tumkur, I, Dr. Prasanna TR, Head of the Department of Orthodontics, warmly welcome you all for the global webinar series of Sri Siddartha Dental College and Hospital, Tumkur, organized by Department of Orthodontics. On this occasion, it gives me immense pleasure to express my deep gratitude and heartfelt thanks to our Honorable Chancellor Sir, Dr. G. Parmeshwara Sir, for his resolute effort and support in fostering quality education to the society. We thank our Vice Chancellor, Dr. Balakrishna Shetty Sir, Registrar M.Z. Kurian Sir, and CEO Dr. Devdas Sir for their continuous support and encouragement in various academic endeavors. With deep sense of gratitude, I sincerely thank our beloved Principal Sir, Dr. Praveen Pudva Sir, who is instrumental in bringing about the global webinar series of SSDC. We thank our Vice Principals, Dr. Nagalakshmi Madam and Dr. Bharti Sir, for continuous support and encouragement in various academic endeavors. Dear friends, it is my honor to welcome and introduce the keynote speaker of today's webinar, Dr. Kiran Kumar HC. Dr. Kiran Kumar HC, he completed his BDS and MDS from Bapuji Dental College and Hospital where he is now professor and head in the Department of Orthodontics, Bapuji Dental College and Hospital, Davangere. He has, to his credit, 15 years of teaching and clinical experience. He has extensively participated in various CD programs and hands-on courses in headgears, mechanics of talk, biomechanics, embedded mechanics, and surgical orthodontics. He has also contributed to the textbook of orthodontics by Dr. Gauri Shankar. At present, he is the convener of Karnataka Orthodontic Study Group. He has received IDA President Award in 1995 from IDA branch Davangere. He had worked in the field of orthodontics, made him achieve that he has achieved Dr. J.G. Kannappan's Award in 2005 and Dr. George Jacob Award in 2014 from the Indian Orthodontics Society. Dear friends, let's welcome Dr. Kiran Kumar for today's webinar. Over to Dr. Kiran sir.
Very good morning to all of you. Okay, very good morning to all of you and warm welcome and wishes from Department of Orthodontics, Bapu College and Hospital, Davangere. I thank Dr. Prasanna for the kind introduction. And this is the faculty in our department. It's our boss, Dr. K. Sadashi Shetty sir, myself, Dr. Vijay sir, Dr. E.T. Prakash, Dr. Deepthi Sri, and Dr. Sharath were all part of my department who have given their valuable time and contributions from the day I have taken up the responsibility. So, Dr. Prasanna actually made a call and asked me to speak on a particular topic in orthodontics. Then I thought, let me speak on orthodontic finishing, a comprehensive approach, which is now a part and parcel in our regular day-to-day mechanics. The presentation has some specific learning objectives. It describes the goals of comprehensive approach, defines the objectives of orthodontic treatment, describes the details of the case, explaining the role of therapeutic diagnosis, exercising the mechanics and mode of torque check, defining the goals of finishing and detailing, auditing the results. So the presentation comprises of 4 cases, which will be dealt, explained in a different perspective and giving importance at particular area where it is very keen for clinician, academician, researcher. The goals of comprehensive orthodontic treatment are to improvise the facial and the dental aesthetics, to achieve optimal dental occlusion, to improve the functional dynamics, and this modality of comprehensive orthodontic treatment should also contribute for the stability of facial structures, and overall it should bring about an improvement in patients' quality of life. The goals and objectives of comprehensive orthodontic treatment is nowhere different from your goals of orthodontic treatment, which is simple Jackson triad, which comprises of structural balance, functional efficiency, aesthetic harmony. Hence, a complete fixed appliance is a very much required to accomplish the objectives and in the final stages, detailing and finishing of the occlusion. We have here a patient by name NR who reported with for chief complaint of forwardly placed upper front teeth. He was self-motivated and he had a positive attitude towards treatment. The clinical examination comprises of an extraoral examination, intraoral examination, and a functional examination. In the comprehensive orthodontic treatment, the goals are not so different. Yes, it's very mandatory that we need to focus on normalizing the jaw basis. That is the macro aesthetics part. So on his frontal examination, his face revealed that he had a mesodolgofacial, increased lower anterofacial height, face is symmetrical, midlines are coincident, and the facial levels are all matching. On his profile examination, he had a protruding forehead, a convex profile, posterior divergence, increased plane angle, and a vertical growth pattern. His nasal and paranasal relationship are quite normal. He had a potentially incompetent lips, negative lip step, and a recessive chin. His intraoral examination revealed an overjet of 7 mm. Dental and midlines are constant. His canine relationship and molarship was end on bilaterally. His oral hygiene status was not so fair. It was quite satisfactory. We have to make a note here that he's not keen on brushing his posterior teeth. His front teeth are quite good. So there is no doubt that during the peak growth period, especially the children present with some amount of marginal gingivitis. Always they present with a concept of marginal gingivitis. So cephalometric evaluation, is it a must that cephalometric evaluation needs to be done in any of the cases which needs some amount of correction, which involves orthopedics? Yes, because cephalometrics is used to ascertain the configuration of the facial skeleton, to know the underlying relationship of the jaw bases, relationship of the axial inclination of the incisors, assessment of the soft tissue morphology, growth pattern, amount, direction, localization of the malocclusion, what are the treatment possibilities and limitations. So when we do a cephalometric analysis, it gives, we can localize the malocclusion. So we not need to depend on only one analysis. We need to do a 3-4 analysis so that we can found a common problem where the underlying deviation is. The skin analysis reveals a retracting mandible, a deficient chin, vertical growth pattern, proclined incisors. McNamara analysis also confirmed the findings of Steener's analysis, retracting mandible, vertical growth pattern, increased lower anterofacial height, forwardly placed lower incisors, which is also supported by our Akasi-Jarabak analysis, indicating a vertical growth pattern, divergent jaw bases, proclined upper and lower incisors, and which also supports by the Squarce analysis, indicating that there's a decrease in the mandibular length, basal length. So when all this analysis is done, the cephalometric analysis also confirms or supports your clinical findings, which gives us a confidence to localize the malocclusion and come to a proper diagnosis. So he was diagnosed as a class 2 skeletal pattern with an A and B angle of 8 degree and width separation showing A width of BO 7 by 7 mm, having end on to class 2 molar and canal relationship, bilaterally with class 2 division 1 incisor relationship, having vertical growth pattern with forwardly placed and proclined upper and lower incisors. When we write a provisional diagnosis, emphasis is made on skeletal tissues, dental tissues, soft tissues, and the continuing dynamics involved in harmonizing the jaw relationship. So it's basically dentofacial deformity. So what causes a dentofacial deformity? Dentofacial deformity is a developmental problem. Occasionally, the deformity is due to a single specific cause, but very frequently or more frequently, it arises from a complex interaction among multiple factors that influence growth and development. So that means in orthopedics or in growth modulation or functional jaw appliances, we need to know the complexity in the development. So postnatally, the maxilla develops entirely by intramembranous ossification, that is opposition of bone at the sutures and surface remodeling. So this is accomplished in two ways. One is the cranial base growth and growth at sutures. Until age 6, cranial base growth is an important part of the maxillary growth, which displaces the entire maxillary complex anteriorly and inferiorly, downwards and forwards. After age 7 and above, cranial base growth stops because it is overtaken by the growth of the soft tissue, which translates the maxilla downwards and forwards, opening up the sutural systems, which is filled in by proliferation of bone and simultaneous surface remodeling. Note, stimuli from the enveloping soft tissue plays an important role from age 7 to 15. The best example is craniofacial synostosis, where there is early fusion of these sutures. We know that in craniofacial synostosis, where there is early fusion of the bones, that is, the sutural response is delayed or it's not responsive. We know that the soft tissue contangium is quite good. The soft tissue is trying to translate, but it is the sutural cells which are not responding because the bones are fused. So this is a best very example that how the stimulus from the enveloping soft tissue plays an important role from age 7 to 15. So we have to know what are the growth. We know the amount of growth, pattern of growth, growth direction. So what are the growth forces? The vertical growth of the mandibular condyles and the descent of the clinoid fossa balance the vertical downward movement of the maxilla, upper alveolar process, downward movement or upward movement of the lower alveolar process, and the downward and forward process of the mandible. That is the body of the mandible. So the harmonious positioning of the maxilla and mandible related to the cranium not only facilitate the ultimate function of the jaw and the teeth to break up food mastication, which was given by Profit, but also forms the anatomical basis of pleasing facial aesthetics, that is the macro aesthetics. So the treatment objectives are to match the skeletal bases, to reduce the midfacial convexity, to achieve lip competency, class 1 molar and canal relationship, to achieve ideal overjet and overbite, to achieve a pleasing profile and soft tissue balance. Coming to the discussion part, the problem is in both vertical and sagittal plane. The vertical descent of the maxilla the vertical descent of the maxilla has resulted in downward and backward rotation of the mandible. So the normal growth of the mandible could not place the mandible in spatial relationship to the face. That means the mandible, though it responded by its all growth factors, but it is not able to achieve a proper position in the face. So that means we need to address this problem. So the vertical growth of the mandibular condyles and descent of the glenoid fossa needs to be addressed, and we need to balance the vertical and downward movement of the maxilla, upper alveolar process and lower alveolar process. That means we have to control the vertical and downward and forward movement of the maxilla. You have to control the downward and forward movement of the maxilla and allow the mandible to express its fullest potential and utilize this during the peak growth period. So the treatment plan was to use an activator and occipital headgear treatment. Activator headgear combination will control the vertical descent of the maxilla and will have an operating effect on the lower incisors. Activator will propel the mandible forwards. Later stages, a non-extraction treatment could be accomplished. We know that the center of resistance for the maxilla and the maxillary dentition, the center of the maxillary dentition is somewhere located between the two premolars, and the center of the maxilla is located inferiorly at the zygomatico-maxillary suture. So we need to splint the dentition, thereby making them as a rigid unit. So an activator was placed because an activator is a rigid appliance. To this appliance, we place the face bow. Following this, application of the force, so that the force passes through the center of resistance of the maxilla and passes through the center of resistance of the dentition, thereby controlling the vertical and downward and forward movement of the maxilla, downward and forward movement of the dentition, holding the maxilla in time in relation to the spatial relationship of the anterior cranial base, allowing the mandible to express its full potential, thereby normalizing the face. So at the end of the post-orthopedic treatment, a relatively fair, acceptable facial balance was achieved with correction of the underlying skeletal malrelationship. Following this, we need to address the mini aesthetics, that is the relationship of the dentition to the maxilla and the mandible. So a non-extraction treatment was accomplished by using MBT prescription O2 slot. We have to make a note here that in this case, there are not much of rotations nor crowding. That means first order, second order, third order movements are quite less. That means at a fair degree, we can accomplish our non-extraction treatment. So he was placed on upper and lower upper O6 niter and lower O4 niter as an initial aligning and leveling wire. Following this, he was placed on upper and lower 1925 niter, because since not much great discrepancies were there, so we could follow a very good sequence as prescribed by MBT treatment mechanics. Following this, we came to the end of the treatment. During the post-treatment, we were able to accomplish all the objectives. That means to normalize the base, achieve good competence of the lips, achieve class on molar, canine, optimal overjet, overbite with center lines coinciding. But however, the soft tissue encompassing the dentition is not so satisfactory. That means some amount of care needs to be taken during the follow-up. So these are the pre-treatment, post-treatment, 2 years post-follow-up. It's well known that from pre-treatment to post-treatment, the quite good improvement was seen. But however, the lip incompetence was still there, and some amount of strain was also seen in the chin area. But in the 2 years post-follow-up, there's a big radical change where there's a good growth of the soft tissue in the area of the chin, which has helped in normalizing or improving the hermetic closure of the lips, which was given by Frankel. So there is a pre-treatment, post-treatment, and 2 years post-follow-up. Intraoral, a good occlusion has been achieved at the end of the treatment, and there's a marked improvement in the soft tissue supporting the dentition as in the follow-up from post-treatment to 2 years. The cephalometric superimposition also supports the corrections which have been achieved during a period of pre-treatment, post-treatment, and the post-follow-up. These are the cephalometric respective changes, which also supports that we were able to address the problems which was localized by using our cephalometric parameters. Following the treatment, we need to audit the case by using for certain indexes. So we regularly use our IoT index where aesthetic component was 3, and at the end of the treatment, we were able to finish at 1. The dental component, it started with a 4A and we were able to finish at 1. And the peer assessment rating index stored the total score was 12. At the end of the treatment, we got 0. That means 100% change was accomplished. So that means in this case, we were able to address the macro aesthetics, micro aesthetics, and the mini aesthetics. Not much involvement was there from the orthodontist in the form of except managing the skeletal malocclusion, improving the dental relationship. The second case, we have a patient by name Gia Rustolius, chief complaint of irregularly placed teeth. She is mesocephalic, mesofacial, convex profile, posterior divergence, and potentially incompetent lips. She had an overjet of 4 meter overbite of 4 meters with upper and lower moderate crowding, 2 in crossbite, molar relationship being end-on and incisor relationship class 2 division 1. Please keep a note on this canine. As we progress in our observation of this case, the canine relationship worsens. The canine position starts worsening. The mixed dentition analysis revealed a tooth metal excess of 5.1 mm in the upper arch and 4.5 in the lower arch. She was diagnosed as a 12-year-old female patient with end-on molar relationship bilaterally superimposed on class 2 skeletal bases with vertical growth pattern, upper and lower anterior crowding, and potentially incompetent lips. Treatment plan was observations was to allow the deciduous teeth to shed on their own, followed by orthodontics with extraction of first premolars in all quadrants, followed by fixed mechanotherapy for detailing and finishing of the occlusion. These are 1-year observation photographs. Now, from the 1-year observation, we can see there's a marked worsening of the canine. The canine position has worsened. And as we progress further, the amount of crowding is also worsened in this case. And there's a lot of chubbiness which is seen in the patient's face, which requires a distribution of fat, which needs to be noted before we start treatment in this case, which is a very must, because we know that during the peak growth period, there is a redistribution of fat, which definitely has its influence on aesthetics of the face. The orthodontic profession has long recognized the need for extracting teeth when supporting bone is insufficient for the amount of tooth structure present. So when to extract and when to initiate mechanotherapy becomes a big question. Traditionally, the extraction of teeth has been immediately followed by appliance therapy. And this is the most common approach still today to prevent adverse and unwanted tooth movement, especially if those teeth adjacent to the extraction sites. Because we presume that the moment we extract, the teeth will drift and we will not be able to correct, and our mechanics can become more complicated. But this is not the same in all the cases. Sometimes doing nothing is also doing something. The potential benefits from a period of physiological dental drift post-extraction, which was first proposed by Bordet, was better and stable occlusal relationship, increased dental layer support, shorter period of full appliance therapy owing to spontaneous realignment of the dentition. It is very well documented, and it's known in histology that we have a good amount of fibers. We have supragingival fibers, dentogingival group of fibers, transeptal group of fibers. These fibers always run from one tooth to another, especially the transeptal fibers play a very key role in maintaining the integrity of the teeth. So, following extraction, we commonly see drifting of the teeth. So that is known as driftodontics. The physiological drift, commonly referred to as driftodontics, following premolar extraction was first coined by Alexander. The advantage of extracting and letting teeth drift is the self-correction and self-suppression that can occur so rapidly under the influence of molding pressure of the tongue and the soft tissue drape supported by the dynamic occlusion. Physiological drift after extractions can significantly simplify treatment mechanics and reduce treatment duration. Following extraction and spontaneous realignment, how does this happen? We know that following extraction, we have a soft tissue continuum which is supporting or trying to make an hermetic closure. The upper lip is trying to meet the lower lip. So there is a continuous pressure which is applied by this pursing effects of the lips onto the dentition. To give a best example for this is especially in a class 2 division 2 malocclusion, we see retroclined incisors, we see a lower lip trap, and we also see that the lower lips are all in a straight line. They are upright on their basal bone. And we, for this effect, for the result of the dentition of this, we point finger at the lower lip. And we say that the lower lip is responsible for the crowding of the incisors and the incisors to be in that particular position. So in that context, we also should accept the fact that following extraction, the lips which are trying to balance themselves will always have a continuous effect on the dentition. And the patient is in the growing period. That means she is in the adolescent growth period. So during this particular period, there's a good response of the tissue to the applied forces. Hormones are released, good chemical reaction and messengers which are responsible for the tooth movement, and the responsiveness of the tooth to applied force also plays a key role. So in that context, following extraction and allowing for the drifting of the teeth, and with an appliance which supports this or which can help the teeth align better, and a optimal planned mechanics will help in better tooth movement. So she was placed on upper 175 coaxial wire with lace pegs following driftodontics. So you can see a very good alignment of the teeth which is accomplished, followed by upper and lower 16 NITA wire. Later, she was placed on upper 14 NITA and lower 16-22 stainless steel with Molyneux's aligning auxiliary. We know that in this case, we had a lateral incisor where its position was so that it was bodily placed lingually. So it is very easy to engage a flexible wire. It's very easy to engage a flexible wire and get it out. No doubt this tooth will move under the influence of the arch wire. But once the appliance is removed, we were not able to correct the root position of this lateral incisor. And it's all well documented in the literature that incomplete tooth movements are all responsible for relapse. And especially when you want to move the tooth, when you have not moved the tooth bodily, that is the body movement of the tooth is not accomplished, then definitely it's going to relapse. So taking into account that, so we used an auxiliary which will help in getting the lateral incisor bodily. Following that, upper and lower 1620 stainless steel with vertical step down bends to get the tooth into alignment using the auxiliary. Following this, we reached upper and 1920 stainless steel and lower 1720 stainless steel with class 2 elastics. We are in upper 1920 stainless steel and lower 1720 stainless steel. We are quite an undersized wire in the lower arch because we wanted to accentuate or make easy for the molar movement. And it's always known that when you want to move a tooth, it's better to go for an undersized wire where friction is quite less. So it's very easy to mesolize the lower posteriors when you're in an interarch mechanics to lower posteriors in undersized wire. Following this, we went for upper and lower 1620 braided stainless steel wire with settling elastics. Settling can be accomplished using 012 NITI, 014 NITI, 016 NITI, 014 preformed stainless steel, 1622 braided wire, 1722 braided wire, 1925 braided wire, 1616 NITI, 1770 NITI, 1622 TMA wire. The list goes on. But to choose a wire, we should know the initial position of the dentition. We know that in this case, there is a significant amount of crowding, and we need to position dentition properly. And in a crowding case, it's always known that root movements takes a lot of time. And we also know that the third order correction using a pre-stitched edgewise appliance is always inefficient. Pre-stitched edgewise appliance is very efficient in our inward corrections and rotations, but it's not so efficient in your third order. So that means when we need to maintain the bite, and we also know that over a period of time, the bite tends to deepen. So that means we need to maintain the bite, and also aid the correction, which was accomplished using stiff wires. So that is the reason. In this case, we have gone for 1622 braided stainless steel wire with settling elastics. These are our post-treatment pictures where we were able to accomplish all the objectives. Quite a reasonable good dental occlusion is achieved, but the detailing of the occlusion needs to be still accomplished, and especially the gingiva, where we can see that there is incomplete retrieval of the gingiva. There is an incomplete retrieval of the gingiva. Post-treatment photographs, the post-treatment radiographs showing the upper incisor inclination and also the mesodistal positioning of the rods, which needs to know that the road parallelism is also an important factor at the final stages of your treatment. Post-retention, 2 years. There's a remarkable change. There's a remarkable change in facial decoration of the patient, which clearly indicates that what the patient expected and what we delivered to the patient both went in hand to hand. Coming to discussion part, it was decided to keep the patient under observation, take into consideration the favorable growth available. Since all the remaining deciduous teeth were mobile, it was decided to allow shedding on their own instead of an active intervention by extracting and placing the patient on holding arches. Following observation, extraction of all first premolars were done and the patient was placed on upper and lower holding arches with posterior composite to gag open the bite and to allow for spontaneous correction of cross bite following restoring of the teeth. Sometimes minor intervention can get maximum correction. It's a common notion that whenever we need some transverse corrections, we need to disocclude the dentition. We know that one of the factors for stability is proper occlusion. So when we know that proper occlusion is one of the factors for stability, that means the proper occlusion will also be a factor which can impede the active corrections. That means a posterior good interdigitation might not help in transverse expansion or correction of the crossbite. So in those cases, it's always better to minimally raise the bite, so disocclude the occlusion, thereby free the dentition, which can accentuate the correction. The reason for allowing physiological drifting of teeth was to take the advantages of the growth of the patient and the soft tissue changes that will be favorable in this patient. You need to use these soft tissue forces. The most common thing which is not addressed in orthodontics, in orthopedics, is the role of the facial soft tissues onto the underlying dentition and the bones. We know that this soft tissue carries a significant amount of dynamic forces which can play a significant role in correcting the malocclusion, positioning the dentition, and also play an important role in stabilizing the dentition and also contribute for long-term retention. Following natural declouding of the dentition, aligning and leveling was accomplished and the detailing of the occlusion was done using fixed appliance. Later, patient was placed on upper big retainer and lower bond retainer. These are the changes that has occurred throughout a period from observation, post-observation, orthodontics, all for extraction and follow-up. Just we need to observe this profile, how it has changed over a period of time. From post-treatment to follow-up, we didn't do anything in this case. It is over a period of time, there is a change which has made better. So this is one which we can't handle. So we need to give time for the tissues to reorganize. Here we have a patient who's 19-year-old, chief complaint of gaps between the upper and front teeth. He was mild class 2 with incompetence of the lips and lower lip trap. You see this face. He's shy. He's not able to expose his dentition. He's not ready to expose his dentition. He's trying to hide the dentition behind his lips. He had a overjet of 7 millimeters, upper moderate spacing, lower mild crowding, and 1-3 in crossbite. Molar relationship was class 1 with incisor relationship with class 2 division 1, and the dental and midlines were not coincident in this case. So with this kind of gaps, teeth in crossbite, which really makes a person not expose his dentition. Street treatment radiographs confirms the clinical findings. Also, we can make a note on the bone underlying bone morphology, bone architecture, density of the bone, and also have a relative good picture relating to the eights and also the measly tipped and locked 2-7. This diagnosed a mild class 2 skeletal pattern with an A and B angle of 5 degree and width separation showing A wide of BO by 3 mm, having class 1 molar relation bilaterally with class 2 division 1 incisor relationship, having an average growth pattern with crocodile upper and please note diminutive both upper lateral incisors. Treatment plan was to go for a non-extraction using O2 to slot MBT prescription, transparatal and 3D lingual arch placed to reinforce the anchorage, which is a part and parcel of our contemporary and comprehensive orthodontics. Composite build-up of upper lateral incisors as Bolton has revealed a malleable anterior excess of 3 mm, which fulfills the interdepartmental work needed to improve the aesthetics of the patient. Segmental aligning was accomplished both in upper and lower arch by using 1/6 NITA wire. Following the placement of TPA and 3D lingual arch in both upper and lower arch, elastic traction was placed in relation to upper premolars for derotation. Our arch wire definitely will derotate. There's no doubt about it. But a free force acting on a premolar will have more moment. So we need to have a system where the moment of force needs to be higher. So by putting a free force and taking support from the TPA, definitely this will aid in easy correction of the premolars, which will also be stabilized by putting in an arch wire. Kessling separator was placed between 2/6 and 2/7 to unlock and observe if the 7 can erupt on its own. Some active mechanics can be installed at the very stages of the treatment of 7, but we need to make a note of it that does this molar has the eruption potential first and foremost. Then to bring the molar into proper position, we need to have a stabilized anchorage segment because most of the cases taking into account is age. If the second molar has not yet erupted, it could be because of so many reasons. Though it looks locked, but sometimes it can undergo ankylosis also. So in that case, our diagnosis is wrong. That means trying to get this 7 using the support of this arch will destabilize the arch and will end up in creating a new malocclusion. Hence, a Kessling separator was placed to know the initial reaction of this 7, whether it is going to respond for active forces if needed to be installed during the further course of the treatment. Once we came to know that the 7 is responding, it was placed on upper 17 finite and lower 1622 stainless steel with a custom-made spring in relation to 2/7 made from an 1/6 NITA archware. The custom-made spring has basically this design, which is simple like a cantilever spring or a finger spring like that, where this spring, when it's engaged in its passive position, when it's engaged, it will have an extruding effect, also a distalizing effect, thereby moving the 7 away from 6. At the same time, we have placed a separator also to make sure that the tooth is unlocked from 6 and will aid in the correction. Following this, upper and lower strengthened by stainless steel with open coil spring between 2/6 and 2/7, to displace the 7 and create space so that later that space can be utilized. Space can be utilized to correct the molar relationship in relation to the 2/6. Upper and lower center stainless steel with open coil spring between 1/2 and 1/4 and sleeve in respect to 2/3. Spring is used to create space, whereas here sleeve is placed so that we have excess space here, but we should not end up in opening the space here and reducing the space here. Because sometimes we overlook our mechanics, thinking that nothing will happen. But so in the next patient, when the patient comes, if the sleeve is not placed here, or if you don't have a stop to maintain the space, so you would have reduced the space here, but you have created space. So again, you have to come back to your mechanics, then create space. So we should not be able to do some roundabout, which ends up in taking most of the time in correcting the malocclusion. Upper 19 stainless steel and piggyback 149 in relation to 1.3 and 2.3 with posterior bite blocks to unlock and lower 1622 reverse curve night wire. We know that in this case we played a reverse curve night wire. The reverse curve night wire will have an intrusive and flaring effect on the lower anteriors and does extrusive effect on the posteriors. Bite block which is placed and which is in proper contact with upper. So it has serving so many purpose. The bite block is trying to overcome the extrusive mechanics which is generated by your reverse coordinate wire. Same time, it has also helped in opening the bite, same time aiding the correction of the canines. So we should have a plan where we should use simple auxiliaries or adjuncts which will aid in our mechanics and improve the efficiency of the tooth movement. Finally, upper 19 stainless steel with sliding jig in relation to 2.6 and lower central stainless with bilateral class 2 elastics, thereby displacing the 6, improve the molar relationship, then get the canine into class 1 and detail the occlusion. At the end of the treatment, we already know that we had a diminutive upper lateral incisors, which was not in proportion to his face, not in proportion to the teeth. So a pre-composite build-up between 1.3 and 2.3, 2.2 and 2.3. A close-up picture was taken, mock-up was done. Finally, it was accomplished where composite restoration was done. So we need not remove all the brackets. We can remove brackets in the intended area of correction. You have the appliance there. Once the restoration is done, then minor detailing of the occlusion, if you still require, can be accomplished with your appliance. These are his post-treatment photographs. We can really appreciate the glare in his face. He was very shy. Now we can see the brightness in his smile, also in his eyes. We were able to accomplish all the objectives: class 1 molar, class 1 canine, spacings, midline constant, arch integrity, arch form, and also the narrowness which was seen in that case where there is not complete fullness seen and a good posterior torque in relation to premolars and molars, which is also supported by our radiographs where optimal position of the upper incisors and proper positioning of the dentition, also a significant improvement which is seen in relation to the 2.7. More time might be required, especially in relation to the bone height which is required in the interdental area. Coming to critical appraisal of this case, a satisfactory occlusal relation and improved facial appearance has been achieved at the end of the treatment. A judicious use of spaces in the upper arch and segmental aligning and leveling in both arches supported our final decision to treat this case non-extraction. Composite buildup managed to match the proportions of anterior teeth and improve the Bolton's discrepancy. And our MBT mechanics or MBT prescription also contributed in achieving this, as we know that there's a differential anterior tip, which is best in those cases where we have maxillary deficiency or mandibular excess. A good intercuspation of the occlusion and soft tissue balance with bonded retainers in both the arches are favorable factors in limiting some aspects of relapse. So his aesthetic components, there's a great change in his aesthetic component. With pre-treatment 6 and at the end of the treatment it was 1. The dental component was 4A at the beginning and at the end it was 1. And our peer assessment rating index. Here we know that score is high, very high. In the previous case, the scores was very low because not in the first case, the score, because most of the positioning of the dentition was quite fine. Whereas in this case, we had crowding, spacing, crossbite, and the ridges, especially the bone heights, were not so good in matching, which is all the marginal ridge discrepancy. That is why at the beginning of the treatment, we have a very high score, and definitely at the end of the treatment, we are able to achieve 100% change. Coming to the last case of the presentation, here we have a patient AVS who was a 19-year-old with an anterior open bite vertical growth pattern, incompetent of the lips, and a lot of strain which is seen in the lips and a sagging face. You see the face is sagging there. Overall, she had a class 1 molar relationship with an anterior open bite from canine to canine with grade 3 gingival recession, grade 2 mobility. To begin with, before the treatment, a free gingival graft was placed to improve the soft tissue in relation to the central incisor. And also, you should make a note on these mammalians. These mammalians are still intact, which clearly shows that the teeth never came into occlusion. That means this problem is there from the day this tooth came into occlusion. That means she has this kind of dental relationship from 8 to 9 years. So indirect bonding was planned using STB OMCO, 018 slot, fabrication of trays, placement of the appliance and upper and lower O2 stainless steel. Following this, upper and lower O4 stainless steel. Once the major part of alignment and leveling was accomplished, shifted to upper and lower O6 stainless steel. Please do keep a watch on this central incisor. Over a period of time, how it significantly improves. And also on these mammalians, upper and lower 1/6 stainless steel, upper and lower 1/8 Austin special place with class 1 forces. At this point of time, you see the mammalians have wound out. That means the day the teeth have come into occlusion, there is a physical contact and a natural wearing which has not occurred, has started appearing in this case. Upper and lower 1/8 Austin special place with class 1 forces, upper and lower 1/8 Austin special place with bilateral class elastics. In lingual mechanotherapy, we have customized archware fabrication where we used 1/8 Austin special place. Especially Austin special place wires are very good resilient wires, high strength wires, maintain the arch form, arch integrity, and also have a good deflection. That means stress strain curve are quite good. They're able to maintain the vertical relationship, especially in these type of cases. So Australian special place wires are quite good wires. She was placed on class 2 elastics to correct the molar relationship, improve the molar relationship, canine relationship. And at the end of the treatment, a fair good result was achieved. And we were able to address both the dental problems as well as its effect on the soft tissue and also bring about an overall change in the facial appearance. We know that in a lingual case or lingual setup, we will not be able to detail the occlusion to a greater level. So once we have reached, maximize our results, it's the time that we can go for removal of the appliance. Probably we can make working models, do a testing setup and place positioners. These positioners have very good effect whereby they have a splinting effect on the dentition, thereby improvising the function, and also it will have a skews effect on the gingiva, which is, we know that as when we place the appliance, the gingiva will be edematous. So when the gingiva is edematous, the products which are released because of that will also are responsible for marked response of the bone, which could play a significant role in relapse of the tooth movements. So hence, at the end of the treatment, when you come, we know that the inflammation, the inflammatory products and the inflammation, not because of the appliance, because of the viral hygiene, should be reduced to a greater extent because we know that there's a direct correlation between the bone loss and inflammation caused by inflammatory products because of inflammation of the gingiva. These are the pictures at the follow-up of 2 years where we can see there's a marked improvement in relation to this central incisor. That means significantly certain treatment procedures can bring about a remarkable change and we can save the tooth naturally. To summarize, orthodontic finishing is not one which we need to bother at the end of the treatment. We have to plan it before. So that means a finishing involves adjustment of individual tooth positions, sagittally, vertical, and transverse. We need to settle the occlusion. We know that a proper occlusion is a potent factor in maintaining or stabilizing the correction achieved. A good occlusion is also responsible for good maintenance of the integrity of the bone, also responsible for withstanding the forces. So in that case, when we need to settle the occlusion, your positioners or invisible retainers for finishing play a very key role, whereby they, at the latest stage of the treatment, where we need to settle the occlusion, allow sufficient amount of time for bone reorganization and adaptation of the underlying tissues. The positioners will do have a splint-like effect on the dentition, maintain the arch form, arch integrity. At the same time, will also indirectly contribute to the maintenance of the dentition. And the role of microaesthetics and mini aesthetic procedures, which needs to be addressed at the final stage of the treatment. Major part, the macroaesthetics and the mini aesthetics is well taken care during the course of the treatment. When it comes to microaesthetics, where there is involvement of aesthetic people in improving the tooth or the tooth form, the tooth integrity, and so many other factors that we need to concentrate. So at the end of the treatment, when we come to know that we have a plan, so it is very important for us to involve our other fraternity specialist so that they can do their value, they can give their valuable opinion and also do a treatment which will definitely improve the overall appearance of the patient. So with this, I thank all of you. So the rich academic and clinical life associated with my department is made possible by teachers, colleagues, residents, and graduating students. We learn more from students from than anybody else. So to all of you, my grateful thanks. And this is one case-based atlas of comprehensive orthodontics, which has been released. So you can avail the benefit of purchasing this book by placing your order at kssorthobapuji@gmail.com. So always begin with an end in the mind. We can't have an end in the middle of the course of the treatment. We need to have an end or end picture in our mind before we make our journey. If we don't know where we are going to reach, then the journey becomes waste. So we know that we need to travel, so that when we travel to a particular place, we need to know what we need to take. So similarly, when we need plan and end in a mind, we know how to treat this case, how to manage that case, what mechanics, how to execute it, where it is changing, what we need to do. So this involves a lot of thinking process. So with this, I thank you, all of you, for your patient listening. I sincerely thank the organizing committee, Dr. Prasanna Tia, who is a very close colleague of mine. I know him very personally. We had a lot of attachments when he was doing a postgraduate. So sincerely thank you. Thank the principal, vice principal, director, dean, chancellor of Siddartha Dental College and the Siddartha institution and the foundation, and also all the people who supported this event and those who have made participated and made it as a great event. If you have any queries, any questions, you can kindly put at bdchortho@gmail.com pertaining to your queries, questions, suggestions, doubts, which will be addressed to you by our department staff pertaining to your queries. Thank you.
You are not allowing him to unmute.
Thank you, sir. It was a wonderful presentation with your case reports, and you gave importance to diagnosis and even the smallest thing, which can give very great changes in cases. And even you have given valuable suggestions like into your mechanics or justification what you're told. And so none of the sessions ends without questions, and few questions asked by participants. And we cannot ask all the questions. We have selected few questions. So one of the question asked by Dr. Vikas is it necessary to downsize the wire when we use Ma auxiliary?
Ma auxiliary. Honors learning auxiliary is an auxiliary fabricated by using a O10 or O9 supreme wires. Our intention of using Ma auxiliary is to get the lateral incisor bodily out. So when you're getting a tooth out, we need to stabilize the other dentition. So in that context, it's better to have a stiff wire. In that context, it's better to stiff wire. But when you are aligning in a low flexible wire, it's not going to have a significant effect since it's a very flexible. It's very flexible, and I can convey only this message, but I can't demonstrate it clinically because we don't have that forum. Possibly, if we get a forum where we can demonstrate and say it, then I think it will be better for them to experience it.
Okay, sir. So another question. At the end of the treatment, to correct the marginal ridge discrepancies, which one do you prefer? Bracket repositioning or wire bending?
It's difficult to answer, but if you're a good wire bender, go for wire bending. If you're a good bracket positioner, do bracket positioning. Choice is yours.
Okay, sir. The last question. At the end of the treatment, if everything is correct, but if there is slight open bite in the posterior molar region, the participant asks, do you want to debond or allow it to correct by debonding and natural settling, or to correct by the orthodontic mechanics?
The question is not specific here. It's a very vague question. Now, when it comes to open bite are of different types. We have a dental open bite, we have a skeletal open bite. And open bite in a growing individual and a non-growing individual. Open bite in class 1, class 2, class 3. So we have a very huge combination is there. So when is a huge combination, when you know that a malocclusion is multifactorial, so open bite is also multifactorial. If they ask that in a simple case, non-extraction case, at the end of the treatment, we are seeing some bite is becoming more shallow. So those things can to some extent can be addressed by your bracket positioning. And we know that in this case, we have planned non-extraction. When plan non-extraction, better to go for extraction of eights, which is commonly suggested that extraction of eights will tend to close the axis. So this is what I could have answered. But we don't have, if you give a particular situation with all the relative data, it's very easy to formulate an answer. To give an answer for this type of question where it's multifactorial, I don't know where it will fit. But generally in open bite cases are more tend to, how deep bite cases are more prone to relapse. Open bite cases are also more prone to relapse. But open bite cases, unless you don't achieve balance between the extraoral and the intraoral forces. It's very well known that the teeth are placed in neutral zone. And we know that teeth should be placed in the neutral zone. That means the extraoral and the intraoral forces should be balanced. When they are not balanced, that means we see deviations in the dentition where they can move in and out, that is transverse, vertical extrusion or intrusion, sagittal proclination or uprighting. So these are the marked changes that we see. So that means if there is no balance, so our objective is to position the teeth and achieve balance or balance them. Most of the times we may not be able to achieve. So in those cases, definitely relapse is going to occur. And open bite cases, we should be very double sure before you debond.
Yeah, okay, sir. Thank you. Thank you for your valuable answers. It was a wonderful, once again, it's a wonderful presentation. Now, I request our beloved principal, Dr. Praveen Kudwa, sir, to give the e-certificate, to present the e-certificate to the speaker. So please, sir.
Good afternoon, sir. On behalf of Sahi University and Sri Siddartha Dental College, I thank you wholeheartedly for accepting our invitation and delivering a beautiful lecture. As the saying goes, wisdom is just not gained by schooling, but by a constant attempt of gaining knowledge. So I really appreciate all the effort you put in for your expertise and delegates and the faculty as well. Thank you, sir. On behalf of SSDC, please accept a certificate of appreciation. And we look forward for many such interactions and having you here at our college as well. Thank you, sir.
Yes, sir. Thank you, sir, for your.
Thank you so much, sir.
Hopefully, we will join, sir, after in the forthcoming months. After once this Corona,
Sure.
hopefully I'll come and join.
Yes.
Thank you, sir. Thank you.
Definitely, sir. Definitely, sir. And I hand over the mic to Dr. Prasanna.
Thank you, sir. Once again, it's thanks to the today's speaker. It was a wonderful presentation. And thanks to the technical committee, Mr. Praveen Udupa, for the supporting this webinar. And thanks to my department staff and PGs, and especially thanks to our college webinar coordinator, Dr. Syed, who is very key person in doing all these things and conducting smooth conduct of the webinar. Thanks to once again, thanks to our principal, sir, Dr. Praveen Udupa, sir. Thank you, sir.
Okay, Prasanna. Thank you. Bye.
Thank you, Kiran Kumar, sir. Thank
you,
you, Prasanna, sir.
Thank you,
And
madam.
thank you, Praveen Kudwa, sir. Sir, shall we end the meeting, sir?
Yes, madam. Yes.
Yes, madam. Yes, madam.
Thank you, sir. Thank you.